live from the Dulles Simons Family Studio, and I had Health Center. I'm supposed to say University of Kansas Health System. It's Friday. It's been a long week. God knows what I'm going to say this morning, so brace yourself, folks. Brace yourself. I'm joined here with Dr. Dana Hawkinson. Hawkeye is back with us. We're going to learn about the numbers in just a minute, but we have some great guests this morning. Roy Jensen is the director of the University of Kansas Cancer Center. Roy and I have known each other for years. We've had a few pinky swears along the way. we have gone through some things here. At Studio B is Dr. Gregory Gann, a radiation oncologist and translational physician scientist here at the University of Kansas. And joining us virtually, Dr. Deepa Polanini, one of our research pulmonary physicians in our division of pulmonary and critical care medicine, and a colleague of mine in cystic fibrosis. These three are going to talk about some interesting and a novel drug trial and repurposing an old medication. So that's the tease. But first, I want to turn to Dana. Yeah. How are we doing this morning?
We're good. You know, it seems like it has been like a full moon all week.
I think it has. I know it has been a full moon. Yes. It has been brutal.
All week, though. Week. But we had really bad numbers, I believe, Monday and the weekend. But really, since then, they've been good, and we've been happy. Anytime we can get lower numbers in the hospital for COVID, we like that. 24 today, 9 of those in the ICU, 6 of those on the ventilator. And as we heard today from Dr. Wild, we're having some people with less stays, few days, to more people. Obviously, if you go to critical illness in the ICU, you're going to be staying longer. So we have had more discharges, but our number of admissions is continuing to creep up slowly, but luckily the total numbers in the hospital are low.
It's that kind of bimodal peak.
Yes.
We have some folks who are old, I don't want to say older, who are sicker, and sometimes older, and then we have people coming in, and we have some shorter hospital stays. Some are 2 or 3 days, and so still needed to be here, kind of make sure they're okay in a course of illness and get some therapies. But I think that we feel fortunate that we've stayed at that level. We do have people here who have been here longer that maybe after 10 or 14 days, the definition from CDC has been that once you're here that period of time, you're no longer shedding virus. You technically are no longer a COVID patient, but they're still here. And so we have an additional number of patients, 10 to 20 patients in the hospital beyond that. But the number that we've been reporting consistently is the number you quoted.
Yeah,
and I think that's what we focus on.
And we'd like to point out, too, it is all age groups. Yeah. And we have family members in the hospital here.
We do. We have a mother-son.
Yeah, and actually the son is, not doing as well as the mother, in critical illness. So the young people are still affected.
Yeah, it's tough. So turning to folks who are working in the area of therapy, gosh, it's great to have everybody here. I'm going to start with Roy Jensen. So Roy, this idea of repurposing an old drug, that's not a new idea.
Not at all. In fact,
you guys have been pioneers in it.
Scott Weir in the Cancer Center has really been a national leader. In fact, has won the Janet Rowley Award last year for that type of approach, and it's really he's done an incredible job.
So talk to us about what it means when we say repurpose an old drug. How does that go about happening? And then kind of set these guys up for that discussion.
Sure. So repurposing is kind of the quickest way to the coast for the development of a new therapeutic. And what's great about it is that a lot of the critical early testing that has to go on in terms of understanding how to give the drug, the safety of the drug, the side effect profile of the drug, all of that has been taken care of. And so what you're doing is you're looking for a new indication for the drug. And that means that, you don't have to do a lot of the earlier studies that were done, in previous years on the drug. You can get right to the question of whether or not it actually is going to work for this new indication.
Yeah, that's amazing. And I know we've had some drugs that have done that here. Talk to us a little bit about some of the past success stories.
Sure. So, phoscyclopirox is probably...
I don't know what that is, so you have to tell us what it is.
That's probably our shining example, and that's a drug that was derived from cyclopirox, which is an antifungal agent, and is now being repurposed for bladder cancer. And it was reformulated from a topical cream into an IV injectable that is excreted into the urine, which is, turns out to be a really good place to be if you're trying to treat bladder cancer. And So that trial is ongoing. In fact, it looks like we're probably going to get a grant to expand that trial into some new indications. So we're super excited about that.
Yeah, it's amazing to take an older drug and find new uses for it that can be really important and save lives. So what a great concept. And we know, as you said, they've already been proven on the safety side of things. So we don't have to go back through all that FDA thing. We just have to show some more efficacy in this new area.
Yeah.
That is amazing. So let's talk to Dr. Gann and Dr. Polanini, because you all have put together some ideas. And we'll start with Dr. Gann. Tell us a little bit about this old drug, and why does a physician scientist and radiation oncologist know about that?
Good morning, everyone. The drug, or at least the pathway that I'm studying is MAP kinase, associated protein kinase 2, or MK2. And for me, as a radiation oncologist, I'm interested in this pathway because of the fact that it plays a role in tumor inflammation, as well as some of the processes associated with treatment resistance and cancer spread metastasis. Interestingly, once COVID had hit, a lot of us, with labs had to slow things down and temporarily shut down in areas. And so, a lot of us were at home reading, and it ended up that I ended up finding that many of the inflammatory cytokines that are upregulated, and leading to the really bad side effects such as ARDS, are seen at very high levels. And these same inflammatory cytokines in COVID, are the same inflammatory cytokines that I was studying, and so this kind of led me down this pathway and everything, where I knew a company, that had a drug that specifically they were studying in autoimmune disorders, and so we were interested in trying to see if we could repurpose this, hopefully, and bring this into use for oncology. We thought, well, this could be a really great opportunity potentially for treating COVID-19. So this was kind of how Dr. Polanini and I, kind of started this path together.
All right, Deepika, talk to us. Help us understand how this could be working in COVID-19 and people with lung disease. Kind of give us the spiel here.
Well, Dr. Stites, as you know, our group has been working on inflammation in CF in a variety of ways, or cystic fibrosis, where I've gotten to practice with you for the last 6 years. Our laboratory and many of the laboratories at KU focused in CF have been looking at hyperinflammation in the lungs. And as Dr. Gann was just stating, the excess inflammation in the lungs in response to the SARS-CoV-2 virus is what we suspect is causing quite a bit of the havoc, so to speak, that leads people from feeling reasonably mildly sick to progressing to having a much more difficult time breathing, and then escalating on to even needing a ventilator, as we've heard about so much. So this therapy is really targeted towards decreasing some of those key cytokines that Dr. Gann was mentioning, IL-6, IL-8, TNF-alpha, IL-1 beta. And Dr. Gann pulled me because we had already been giving research presentations where we'd overlapped with each other, and he knew that these were cytokines that we are actively studying in cystic fibrosis. So I guess part of the moral of the story here is that although the SARS-CoV-2 virus is novel, the story of inflammation in the lungs is not, and we are all looking at ways to try to quell that down in a safe manner.
So how do you plan to study it here at KU?
Carefully, for starters. So we did have to go through FDA approval, although this drug has been studied in phase 1 studies of healthy volunteers and individuals with rheumatoid arthritis, and I'll leave it to Dr. Gann to discuss those details a little bit more. The FDA did, of course, want to see a number of checks as related to the fact that this has not been studied in COVID-19. So this actually can be found on the clinicaltrials.gov website. It's, of course, a registered study, and we did receive IND approval from the FDA to proceed. We are seeking about 36 participants in the study. Right now, we are a single site, and unfortunately, as COVID has continued to clip its way through the metro area, we have been certainly seeing cases that are eligible to come into the study. And we truly seek participation because I think one of the things that we're all struggling with, I know Dr. Hawkinson and Dr. Jensen would agree, is the general lack of data from randomized control trials, but we're starting to make progress in that realm. Certainly Dr. Gann and I are seeking to contribute to that.
All right. So, Dr. Gunn, how many folks do you hope to recruit from here at KU?
Yeah, so we're hoping to recruit up to 36 patients.
Right. And any other centers that you're talking to join?
Yeah, so currently KU is the only site that has access to this trial. We are looking for for other partners and everything like that around the locally as well as around the nation. So hopefully, and everything we'll find one or two other sites that will be able to help us with opening this.
Yeah. Emily said he's listening today and will be wanting to jump into that fray because we know that lung disease is really probably the most common pathway. There are others, but probably the most common pathway to death, and as a consequence of COVID-19. So lots of work being done to try to help quell that, and so your work is incredibly important in that. So thank you guys so much. Well, Jill, let's first ask if there are questions from media that have popped up this morning.
Hi, good morning. We had a question about the numbers that you guys give every day for your COVID-19 patients, asking if those numbers include people that are only in the hospital for COVID-19 or if people that have other conditions and also have COVID-19 are included in that, if that makes sense.
It does, and so we'll take that on because the CDC and HHS, they've sort of shifted definitions back and forth about what you're supposed to report. Here's what we can tell you: anybody that comes in the hospital with a positive test, we report with COVID-19. After 10 days, originally, that definition then lapsed because you would no longer be infectious and give it to someone else. So then we stopped counting you. What we know is that we have other patients who are hospitalized who have therefore are here longer than 10 days from COVID-19 who we don't report. So our numbers are more of an acute report. They're usually a report of the more recent cases that have come in. Mm-hmm. We do have an additional number of patients that have been here longer. Then the HHS has now said, we want you to report even patients who have had COVID-19 who come back into the hospital. Let's say, you're 3 months out and you still got to go get your gallbladder fixed. Well, if you've ever had COVID-19, you come back 3 months later and you're still reported to the HHS database day now. I think I got that right.
Yeah, absolutely. We do have a number of patients that we consider not needing isolation. We don't want to say recovered because we know that patients can still have symptoms. But to Dr. Steitz's point, they are not really considered infectious at that point. So we do have a number of patients in the hospital who we've moved off of our COVID cohorting units who have still come in either for surgeries or for another reason or for COVID itself who've been diagnosed with COVID.
And what we know is that the way we report it to you is the same way we've reported it since we started this crisis, which would fit the original definition. And so when we report to HHS now, we have to report a different number. And so when you talk to a health system and ask them how many they have, you almost have to, there are two things. I think the consistency is incredibly important so you can follow that number over time, and so we've done it, we've reported it the same way over time. But if you actually want to know total number of patients, you have to actually ask a slightly different question. And I would tell you the exact number. I don't know that total number today, so I don't want to mislead you.
But I think the important point is the numbers that we have been reporting, as Steve said, are for the acute patients that we're actively treating or enrolling in trials. For instance, I do have a patient with Dipica that is enrolled in our trial right now. That is certainly counted towards our acute numbers.
So you guys have already enrolled some folks into your trial, Deepika.
I'll leave it to Greg. We are actively enrolling, correct?
Good deal. How many folks have you enrolled?
Greg, do you want to speak to that? I'm actually not totally sure, Dr. Steitz, that we're allowed to disclose that.
Fair enough.
Yeah.
All right. Next question.
Yeah.
From media. All right, we're back to the public.
Cody wants to know, what is the name of the cancer drug again being used in this trial?
All right, Deepika or Greg, Dr. Gann, tell us what that name is.
Yeah, so the name of the drug is ATI 450. It is actually not being used in cancer right now. The company is hoping to study this in rheumatoid arthritis. We've only kind of come, or that I've only come into it just because of the fact that I study this same pathway in cancer. So I'm hoping that I'll be able to find opportunities to work with this drug further in cancer. So but for now, we're hopefully going to use it for COVID-19. Hopefully we'll see something with it.
Please go ahead.
Oh, I was just talking about individual asking the question that you can look this up under the name ATI 450. So that's A like Apple, T like Tom, I like India 450. And that will actually lead you to finding this on clinicaltrials.gov, where you can learn a lot more about the trial itself and all of the disclosed information for FDA and more. And you can also search under Dr. Gahn's name or my name with that same drug name, and that will bring you up to the press release from the company.
And David, just to say, you and I practice an area where we've done some repurposing of old drugs. Azithromycin, antibiotic, but in cystic fibrosis, anti-inflammatory, man, it works pretty well both ways.
Correct. I think that's one of the really exciting things that's been happening at KU through COVID research. As Dr. Jensen has pointed out, the collaboration between the Cancer Center and the Department of Internal Medicine here has been really exciting and fruitful. Certainly, we've seen this before, but certainly new in COVID-19. And we have a variety of trials occurring, ranging from the vaccines to repurposing existing drugs that are already used for things like blood pressure to new investigative agents in the space like the one Dr. Gahn and I are working on. So there's a full range and more.
That's pretty exciting. And as the region's only NCI center, Dr. Jensen, it's got to make you proud to watch these people do this kind of great work.
Sure. It's, well, when Greg originally came up with the idea, it coincided with the time when we were working with a large number of the leadership across the medical center to really figure out how we were going to do clinical research in this area. And one of the first things that we established was a disease working group along the same lines that we do in the Cancer Center for, say, lung cancer or leukemia or whatnot, where we bring an entire spectrum of disciplines together to really figure out how we're going to prioritize these things, how we're going to put them into practice, and to develop the trials. And so that whole infrastructure from the Cancer Center essentially got replicated and repurposed for this reason.
That's awesome. And just to say, the drive toward comprehensive, how many days, how many hours?
Well, it's going in September 27th of 2021.
That's like right around the corner, man.
Yep. So about a year and a month.
All right. And we're ready.
We will be ready.
I know we will. All right.
Cody had one follow-up question. The people that you'd like in these trials, they have to be active, acute COVID patients.
Okay, did you guys hear that? Do the folks in these trials need to be active acute COVID patients?
That we are looking for are those who test positive for COVID-19. They have to become hospitalized, unfortunately, and have significant enough respiratory symptoms to need oxygen support.
Okay.
Cindy wants to know, does everyone who's hospitalized with COVID experience cytokine storm?
Does everybody get that cytokine storm? Dana, I don't think everyone has it because there are different modalities of injury with COVID-19.
Yeah, absolutely. We don't feel that they do. A lot of the people that end up in the critical illness in the ICU probably get that cytokine storm. Most of the people who are at home, who are never have to be hospitalized, the people here at the hospital with mild to moderate probably do not experience that cytokine storm. Again, that is going to that is part of the immune dysregulation, and that what causes all the inflammatory process, the things that you see in the lung, probably the heart, the kidneys, all of that type. Again, mostly it's associated with the lung, and most people are familiar with the lung aspect of that.
And I would say, Deepika, there's varying levels of that. So some people may have a little bit of storm, not get too sick at all, and some people get a whole lot of storm.
That's my research for the last 10 years is trying to understand in drugs like diseases like cystic fibrosis why some people, even twins, with CF, one can be doing so much better than the other. And what we've learned in the last decade is that we really do see that there may be an underlying genetic propensity towards having hyperinflammation. So not all inflammation is the same. And, some of that may actually explain why some people with COVID can fare so much better. Some do so much worse. But Dr. Gahn and I have designed the trial to selectively pick those people who are on that cusp of really going south with cytokine release syndrome to see if we can abrogate that.
Yeah. And so there's even a little bit of good storm. You want a little bit of inflammation to help defeat the infection. It's when it kind of gets a little short-circuited and things go a little haywire.
Right. And there were several safety points that we designed into the trial design and are continuing to monitor to make sure that, inflammation is not oversuppressed. So it is that fine balance that we definitely seek in the world of inflammation in the lung.
Yeah. Okay. Jill, next question.
Melissa worries about people who might get COVID and flu at the same time. Can that happen? Would they result in a cytokine storm?
Oh, boy, that's a good one. I'll come back to both of you again. Let's start, Dana. You and I kind of live in terror. We've had this question on the show a few times. Mm-hmm. We live a little bit in terror of this idea that you're going to have both influenza and COVID-19.
Yeah.
And that's not uncommon with some viruses in children.
Correct.
Adults a little bit different.
Yeah, and even in especially patients who are immune suppressed, like bone marrow transplant patients, we can infrequently see people who are diagnosed with one or two respiratory viruses.
And you said infrequently see, not frequently see.
Yeah, but even in the bone marrow, we do see people who have two viruses, but yes, infrequently, even in that population, but it can be seen. That was our concern initially, and that is our concern moving into the influenza season. Will you have a co-infection with influenza and COVID? That is certainly possible. A co-infection with COVID and another respiratory virus, that is possible as well. So we are preparing for that. We anticipate that. We hope it will be less. If there's any indication from the Australia data, currently in the influenza season there, we've seen that there's been a large decrease in their influenza rates overall. We still need to promote and endorse vaccination when you can get it, and also continue the hygiene practices, the public health practices of the masking, the distancing. Hopefully that will decrease the amount of co-infection.
Yeah, and just to say, this is a message to all of our listening audience. Make sure you get your flu shot because that'll help mitigate and to diminish that thing. So, okay, Deepika.
I don't think we know, and Deepika can maybe speak to this, I don't think we know how it will impact cytokine storm. We know that the virus, COVID-19, does have immune evasion. One of the biggest things is when you first get infected, it decreases your interferon response. That's one of your cytokines. And then after, as you've seen the virus more and it's replicating, your immune system comes back, and that's when we see the immune dysregulation, the cytokine storm. And I don't know if Dr. Polanini has more comments.
Deepika thought about that, but especially the combination of influenza and COVID-19, which just sounds bad. Mm-hmm. So get a flu shot.
Yeah, clinically, I could not recommend more that people do get their flu vaccine and continue to practice the same levels of hand hygiene, avoiding touching our faces. Things that protect us from the SARS-CoV-2 virus in that manner are also going to protect us from influenza. I would have to defer to Dr. Hawkinson, but I think we simply just have not had enough time outside of other regions of the world, as he's speaking to. One thing I can say that we know from looking at the cystic fibrosis community, we know that, our lungs, no matter whether you have a disease state or not, are not sterile organs. And so there's really a fine, harmony or network of microorganisms that are existing at all times. So I think it really remains to be seen whether, an environment that has SARS-CoV-2 in the lung is even hospitable for co-infection with certain other organisms. But no matter what the theoreticals, it does not sound good in a clinical capacity. And we really don't want to be faced with taking care of patients with two very serious viruses in their lungs. So we really, as you're saying, encourage everybody to pursue their flu vaccines this year and keep up great hand hygiene and more.
You bet. Okay.
Wayne is asking, is there a thought that those who have the strong storm are the ones with lasting effect, long-term organ damage?
Oh, that's a great question, too. So, guys, let's take a look. Dana will comment on that. I want to talk about it in sports, but let's talk to you two first. Mm-hmm. What do you think? Are those who have cytokine storms going to have some of the longer-term damage, Greg?
Yeah, no. I think I think there's there's definitely some literature out there that suggests that those who have that leads to this somewhat uncontrolled inflammatory reaction, which can lead to this a lot of end organ injury, such as the lungs and everything. And I think there are definitely some cell types that that people have been looking at, macrophages, neutrophils, that can get activated, and in doing so, lead to a lot of that inflammation that that persists, and then the long-term fibrosis injury that, I think people are starting, that we've heard about. People are having a harder time and everything like that, with their energy, catching their breath and trying to recover from this. And so it's something that I think, we still need, we still need a lot of research, and definitely we need to, we're spending a lot of time and everything focusing on looking at this illness kind of in this acute phase, but I think there's a lot more work that has to be done, for kind of those who recover afterwards, and to kind of look at these long-term effects and to see maybe there are other things that we'll have to do. Do we need more anti-inflammatory medication? Do we need more pulmonary and/or other kind of recuperative work, to try and get many of our patients who suffer from the severe COVID-19 illness back up to full speed.
Deepika, other thoughts?
Just that I would say after 10 years of studying inflammation and cystic fibrosis, a lung disease that in itself is defined by fibrosis, we do conclude that there is definitely a correlation between higher levels of inflammation and accelerated paths towards fibrosis and long-term scarring and damage. So that was one of a larger studies of samples from respiratory tracts and people with this disease. I would extrapolate that similarly. We really want to try to dampen this inflammation down to a safe and correct level, and that's how Dr. Gahn and I got started on this study.
Yeah, it is interesting, though. We do know from the German study looking at myocarditis that the MRAs of hearts in people who had recovered up to 10 weeks out still had a lot of inflammation. Some of these people were not very severe, and yet they had myocarditis at 10 weeks on an MRI. So that's a concern to us. And we also know some preliminary data coming out of athletics that people who are even asymptomatic and testing positive for COVID-19 are showing myocardial inflammation, and raising the question whether or not you're safe to return to sports. And so, man, this disease we clearly know that if you're bad, you're bad. Got that one down. The question is, even if you're not bad, are you bad? And man, that's a little spooky, and that's one of the things that I think has been so challenging for us about COVID-19. The flip side of that is that how long does that inflammation last before things begin to die down and we can trust that it's safe? Thoughts about that from you two?
Well, I just want to offer that, I think Dr. Gahn's insight to try to bring this pathway into therapy with COVID-19 is really right now focused in the trial design and description that we've discussed. But so much of this phase of the trial is really to look at safety. So to speak to the points you just raised in milder cases where inflammation may be persisting, once we can learn more about both the effectiveness and safety in this phase of the trial, there could be a future towards looking at whether or not it could even prevent inflammation, the kinds of cases you're describing.
Roy, one of the remarkable things about science, and Deepika, she and I have been doing CF for a long time, and we know good medicine at the bedside, that all makes a really big difference in how people do. But the reality is that it's research from bench to bedside that truly changes outcomes. And we know that our new drug, Trikafta, a way of really repairing some of the protein channels in CF, has made a remarkable difference in patients' lives, far better than any of the other advances we do. Talk to us a little bit about that bench to bedside story, because when it comes to COVID-19, I think that's where we're going to find hope.
Yeah, and I think if there is a silver lining to this pandemic, I think the public is going to have a much better concept of what is involved in really figuring out a scientific question like this. And, we were pretty much flat-footed in terms of COVID-19 as of January 1, and look how far we've come. I think, you look at the death rate from early hospitalizations.
Much higher.
Much higher. I think we're getting much better at taking care of these patients. I think we have better ideas in terms of infection control, and even that continues to evolve. As far as, well, is it droplets? Is it aerosols? It's like, and
what does that mean?
That seems to be changing, and it's not that, and I don't want people to confuse this. Well, they don't know what they're talking about, so we just have to dismiss all this. It evolves, and it's complicated, and we have to recognize that complexity, or else we're going to fall victim to it, frankly. And I think people just have to understand that we have to deal with this on the basis of real knowledge and information, and that it takes a while to collect good information and to understand what the right path is.
It does. And the miracle of sciences, as we're doing a lot of it, you're right, we've learned a lot. I just think, Dana, how long it took and just AIDS therapy before the diagnosis of when we first started learning about it in the late 80s until we had effective therapy. That was like 2 decades.
Yeah, and even the long-term effects of what happens when somebody does have HIV or AIDS and they get treatment, but you still have had the infection. What happens decades after that? You know, how does it affect the brain? How does it affect organs? Certainly, I think we have the best evidence for this post-COVID infection period because it is still in the infancy, as you talked about, Roy. As we start to see more patients who have survived, we know there's probably very good evidence to suggest that if you've had critical illness and you have all that inflammation in your lung, it can take time to resolve, if it resolves at all. You can still have scarring and possibly fibrosis. We still don't know to what extent. You know, all the other organs, you know, for the kidneys and the GI tract, it looks like people who recover don't really have too many problems from that. But again, we still need to do a lot more research. The bigger question, as you talked about with the sports, is what really happens when you have severe or critical illness to your heart? What happens after that? And also to your brain? Is there this brain fog that Dr. Rippey was talking about? So certainly we still need to study those long-term effects. As far as immunology, we think that people who have critical illness may or may not mount a larger response. Certainly, studies have shown that they may have higher antibody titers, but that, again, doesn't include the T-cell immune system as well. So we are still learning about that as well.
So many questions. Need more answers.
Oh, yeah, and they're just flying in. Lindsay wants to know, if I'm at home with COVID and I'm treating myself, what medicine should I take and not take?
Okay, Dana.
Yeah. So I would not get any, we are not prescribing any hydroxychloroquine or azithromycin. If you are at home, and we have said that 80% of people will not have to seek medical attention, so that's good. So it's all supportive care. So it's fluids, it's nutrition, and if you have to reduce a fever, you know, Tylenol or ibuprofen or something of that nature is going to be perfectly acceptable.
David can talk to us a little bit. I'm sure you've thought a little bit about the whole hydroxychloroquine, azithromycin, and zinc thing. That still swirls out there, and now it's back a little bit for people with very early disease or more mild symptoms. What are your thoughts about that?
My thoughts on it are really that we need randomized controlled trials. I think Dr. Hawkinson and I were just talking about this 2 days ago. We see signal in some of these studies, but it's just so difficult to know because anytime that we're doing research, we're taking a small collection of people and trying to extrapolate that to a much bigger population. And it is extremely difficult to understand what the true effect of a treatment is unless you've had the opportunity to compare it in a controlled way against a placebo, or what we used to call a sugar pill. Now, just basically a tablet with nothing active. And that is the only true way to understand if a treatment is really having a significant effect in the kind of circumstance that we're in right now. And so far, we did not see that with the initial hydroxychloroquine trial that had so much publicity. Unfortunately, that was not a controlled trial. So at this time, as Dr. Hawkinson has previously talked about, we do have some signal of seeing decreased time with the virus with remdesivir. We do know that there is a benefit with steroids now, like dexamethasone for certain populations, but we need more randomized controlled trials.
We say it's the big four here. It's the dexamethasone, steroids, anticoagulation, convalescent serum, and remdesivir. That's what we've got that we know for sure. Hydroxychloroquine, man, it reminds me of digoxin. For those of us who've been in medicine for a long time, Roy rolls his eyes because we know, right? I mean, Dig was a big thing for a while, then it faded. Then it was a big thing for a while, then it faded. Then it was a big thing for a while. I think, okay, here it comes back again. And Theophylline, a pulmonary drug, has that same story. So I think hydroxychloroquine clearly works in malaria, clearly works in some other very mild autoimmune disease.
Yep.
Not great in more severe COVID-19. Does it have a role in early COVID-19? I don't know. I just don't know the answer to that.
Yeah, and we know from people, again, who are taking it for purposes that it was FDA approved, that it doesn't prevent infection nor advancement to hospitalization either. So
that's kind of bad news
Yeah.
for that, but so we'll see.
You know, the other thing I would add to that question is if supportive measures and kind of generalized things that you do for the flu are not working, then you probably need to come in to seek medical care.
That's right.
So don't mess around.
Don't hesitate.
Right.
Yeah.
Because now we do have some things in the hospital that can help modify the course of the disease. And to your earlier point, there are death rates at 30%. Now our death rate hangs right at 9%. And I think that is, we're a little better and we know more about what we don't know. We just don't know enough. Jill.
Yeah, a lot of people are asking about when to get the flu shot. They normally get it in October.
Yeah.
Are you advocating they run and get it right now? And will it last?
Okay, Dana. You're the flu king.
yeah, so we
Although I've
tried
had
to
flu the
address
last
this.
3 years with my shot, I might point
Really?
out, but yeah. So
So the influenza vaccine will not give you influenza. We always advocate, and certainly the CDC advocates for never missing an opportunity to get vaccinated. Now, luckily, we have a lot of pharmacies and other entities that are offering flu shots. So it's not just when you go to your physician's office. I think a lot of that will depend on how high flu activity is at any given point. Again, from about September to April or so is what we consider influenza season. If it's low, and you have good access to influenza vaccines, certainly for my HIV patients, I really do recommend October, early November-ish, really not past that. And that will give you lasting immunity through the end of influenza season. Right now, there is not a general recommendation for an influenza booster. But if not, if you are otherwise going to see your physician and they're offering them and you don't have other opportunities down the line, we don't want to miss that opportunity to vaccinate.
All right, some people are asking, you mentioned that we have patients that are in here that have been here for a long time. They want to know how many and what's a long time.
yeah, I don't know the time. I know it's more than 2 weeks and sometimes up to 4 or 6
Yeah.
weeks, and I just don't know the exact length of time. And I don't want to quote the exact numbers. I'm not sure. I think it's around 10 to 20 folks, but
I think it's around the 20-ish, yeah.
Yeah.
So we don't,
and it
We're
goes
doing
up and
numbers on
down.
Monday. Maybe we could find that.
Yeah,
Okay.
we'll do that. Well, I'll talk to Dr. Wild about that because he's going to come on this program. He's kind of our numbers king, and we'll have
Yeah.
him go through that and talk a little bit about that. Because on Monday we're going to go through that. We're going to go through some more death statistics as well as statistics about race and gender and how COVID affects different patients differently here at our own health system and thus in our area. And I think that that's an important discussion for people to have because we want folks to understand that COVID is real. So, Dr. Gann, as you look at the science and you look at the therapy that you guys are designing and working with, tell us what your hope is as a result of this. Where do you hope this is going to go? What's your hope for it?
Yeah, no. Again, obviously my hope is that this will, that this will be a drug that will hopefully help, reduce, the severity of some of the symptoms for COVID-19, and that'll hopefully prevent patients and everything. Our primary endpoint, is hopefully to have an improvement in respiratory failure-free survival. But with that, I think, to highlight the points that many of your guests and everything have already pointed out, we need a randomized controlled trial and everything to try and really address this question definitively. So right now, our trial is a signal finding study as well as a safety study, and based on the findings of this, if the results are positive at the end of the trial, then the hope would be to try and advance this into a larger scale national study so that we can try and address this, address this question more thoroughly. So,
And is it,
I think the science, however, is promising.
Pill, IV, injection, how is it given?
Yeah, so the drug itself is a pill, and you would take the pill twice a day.
The pill thing more than the injection thing.
yeah.
People are asking questions.
Yeah.
People are asking questions about travel. Some people are planning to go to New York in October. People are talking about going to Colorado. They want your thoughts on flying, driving, or those places
Oh,
staying.
yeah, here we go, flying and driving. Okay. You've heard me say before, I'm a driver, and I like to fly. Actually, I really enjoy flying, but right now I'm trying to avoid flying as much as possible, just because planes are well-established areas where even though they try to empty the air, recirculate the air, and do things, you're still in more close quarters. It's kind of like being in a smaller room with a lot of people, and that's when you don't like it. And so try to avoid flying as much as you can. If you are going to have to fly, then wear a mask, wear some goggles, take your hand sanitizer, be as safe as you can, try to distance yourself from others. But I know we were talking to one of our docs earlier this morning that he said, gosh, I flew out to taking my son to school out in Philadelphia, and then and it was pretty empty. He came back, it was pretty crowded, and you just don't know. So I think driving can be really safe, and then when you go somewhere, because you're by yourself, your bubble is, but when you go, it's all about how you conduct yourself. Kansas and Missouri, we have pretty high rates of COVID-19, so traveling isn't like you're going to go find other places that are really a lot higher, unless maybe you go to Florida. But by and large, it's about what you do when you're there. If you go out in a big group settings, you go out and sit at a bar, you go to dinner in crowded restaurants, yeah, okay, well, you could do that in Kansas City, and it's all going to be a risk, and the risk isn't different, it's still there. So it's really about what you do. And you guys have heard me talk about my travel, because that's how I maintain my sanity, but I tend to go out in the woods, and fortunately, trees have not yet been found to convey COVID-19 even when the wind blows. And so I think that what I try to do is go find places where I know there's things that I can do that are safe. And I think Colorado is a great example of that. And only don't start a fire out there. There's a lot of fires going on in Colorado.
Yeah, I think air travel right now is different than 2 months ago when I flew. I would not fly right now for all the things that you mentioned, but also the proximity and the amount of people in the airports themselves. So I think it is a very risky proposition. You have to continue to do the things that we have talked about. If flight is essential for you and you need to go, that is eye protection, masking, hand sanitizer. Try and maintain your distance as much as from people as possible when waiting in the airport and doing those things. But it is certainly a riskier proposition now than it was 2 months ago.
Yeah, and I know that just the rate of infection we're seeing in our testing has gone up a little. So we know it's more prevalent out there. So I think that's our advice. Be safe. And I don't know, Deepika, if you or Greg have any other thoughts about that? We always hear that question.
Regarding travel, I guess I would just agree. I think that because we actually had started to hope to see a little bit of a lull, but have seen this uptick, I think now is the time to really think of creative ways to spend time with family outdoors, safely, just containing your travel with driving only with your immediate family members. That's personally what I would pursue right now.
Okay. Roy, you been traveling?
No, I have not. And I'm a big car person. I find it astounding that the FAA has allowed the middle seat to be utilized.
Yeah,
absolutely.
I mean, it's just like, this is such an obvious thing that they should do. And I think if you could point to one thing, a very simple infection control measure that could be implemented that would significantly improve air
Safety.
Travel.
Yeah, there you go.
That's it.
Yep.
They don't do it.
Okay. So I think we are probably at time. We probably need to wrap up. We always like to have a lot of questions. Any last question? Or think we're...
There's some people that are asking, if one person in the household tests positive and then the other person tests positive, do they still need to isolate?
Yeah, that's a great question, Dana. What do you think?
I think you should isolate if one person tests positive to try and prevent the spread. There are varying rates of household spread. Now, if two people are testing positive within that, I think it's probably okay to maintain your bubble, but I would isolate yourselves away from other people.
And we still don't know what if you're both shedding virus, are you going to make each other sicker by shedding more virus? I don't know the answer to that. That gives me the nerve, a little bit of the willies still. I think I'd tell it, maintain a little distance. Let's not do too much stuff right there. I think be a little careful. So, all right, guys, final thoughts for today. Greg?
Yeah, no. Thank you very much, and everything for giving us this opportunity, and as well, we definitely want to emphasize to the public and everything that definitely follow your healthcare providers' recommendations and everything. Definitely wear your mask. Definitely practice safe hygiene, and if family members or people that and everything that should become hospitalized and everything that, just realize and everything that we have opportunities at our many other hospitals for clinical studies. So we definitely want to encourage people to consider those clinical studies, because that's the only way we're going to be able to make real meaningful progress moving forward with this, with this terrible illness.
Deepika, any other final thoughts?
Oh, I just want to say that I feel really fortunate to work at the community that KU is. And so I really want to thank Greg for coming up with this idea and pulling me in, and really thank Dr. Jensen for putting the weight and the support of the Cancer Center behind us. I think that, Greg and I have turned into a great friendship and partnership. I know I've become closer with Dr. Hawkinson over the months, and I just think it's really speaks to what our community at KU does when we're working together and trying to take care of our community outside of.
You bet. That's why we're here. That's why it's an academic medical center, right, Jensen?
Yeah, no, I think, the partnership between Greg and Deepika is, I think, emblematic of the response of this institution to the pandemic. And I'm really proud of their efforts, and, wish you all the success.
Yep. Do well, folks. Be well out there. Any final thoughts today?
I think that was a good question brought up earlier about what we've talked about from the earliest days. 80 to 85% of the people will not have to seek medical attention. That small percentage will. If you are home, supportive therapy is good. Fluids, nutrition, if you need to use some fever reducer, Tylenol or even a little bit of ibuprofen is going to be good. And as Dr. Jensen said, if you feel that you aren't getting better, at that point it's probably time to seek medical care.
All right, so hey, we wrap up today. Dr. David Weil, we mentioned him earlier today, and Dr. Aaron Corvo, the Deputy Medical Officer for the Unified Government here in Wyandotte, will be here. This will be talking about our deaths and the numbers here. So I think that'll be a really important presentation for folks to hear. A couple of cool mass photos. Nancy is a pet sitter. Her mask may have confused her cat, so it could be a perfect day. Yolanda shares a socially distanced 60th anniversary. Congratulations, 60 years, that's awesome. They want us to know that they pulled their masks down for a photo op and then put them back up over their chin. And finally, a 1-year-old Allison and mom at a grocery store staying safe. Now, that's impressive. I'm not sure what all's on Allison's mask there, but it looks better up there than it looked on my picture. So there you go. That looks great. So congratulations for that one. Hey, you know what? Pandemics are hard, right? Pandemics are just hard, and they're wearying. I wrote a note to a friend of mine last night. I said, I'm just weary. That's true for all of us. How do you stay safe when you're weary? You do the things we tell you to do every day. You wear a mask, you eat, you take care of yourself, keep yourself distance, wash your hands, cough in your elbow. Don't go outside if you're sick. Don't go out into those large public gatherings. It sounds like so much fun until you get COVID-19. Because you know what? That ain't fun. So stay safe, and still remember, there's no place like home. But there's a lot of hope. Let's be a part of that together.